Let's dive right into this explainer. Today, we're putting on our detective hats and stepping straight into the world of male reproductive diagnostics. We're going to break down the evaluation of male infertility and erectile dysfunction by looking at precise physiological cues, anatomical roadblocks, and some really fascinating real-time hemodynamic data. It is an amazing journey, so let's get right to it. Okay, let's dive into this. Here is our clinical roadmap for today. We'll start by unmasking male infertility, track down testicular and obstructive causes, and then shift gears into ED etiologies, the mechanics of an erection, the penile Doppler exam, and finally, diagnosing vascular dysfunction. Starting off with Section 1, unmasking male infertility and understanding the true scope of the problem.
Before we go tracking down specific culprits, we really need to understand why a structured workup is so absolutely crucial. Historically, when a couple faced challenges conceiving, the diagnostic focus almost always leaned heavily toward female factors. But look at the actual numbers. Male causes alone account for 20% of infertility cases, and combined causes make up another 27%. That means male factors are involved in nearly half, 47% of all infertility cases. That makes a thorough male workup completely essential.
To ground our investigation, we need a clear clinical threshold. Basically, male infertility is defined as the failure to achieve pregnancy after one solid year of frequent unprotected intercourse. Once that one-year mark is hit, the investigation is officially on. We first rule out the systemic stuff, prolactinomas, Klinefelter syndrome, maybe anabolic steroid use, but once those are cleared, our diagnostic funnel really starts to narrow down.
Moving right along to Section 2, testicular and obstructive causes, this is where we actually track down the culprit. As we move down that clinical funnel to figure out where the pathways are compromised, our first major clue is the semen analysis. We're particularly looking out for low or completely absent sperm counts. What's fascinating here is how a simple volume and fructose test acts as this massive fork in the road. A volume greater than 1 milliliter combined with positive fructose strongly points to testicular or paratesticular causes, which means it's time to order a scrotal ultrasound. But if the volume is under 1 milliliter and the fructose is negative, that points us toward a distal transport obstruction, meaning we need a transrectal ultrasound, or TRUS. Now, if we go down that TRUS pathway hunting for an obstruction, this specific anatomy is exactly what we're looking for. A Müllerian duct cyst or a utricle cyst can sit perfectly positioned right near the prostate and ejaculatory ducts to physically block that distal pathway. It's a literal structural roadblock preventing transport, which perfectly explains that low-volume, fructose-negative result we just talked about. On the flip side, if we're looking at testicular causes, we absolutely have to talk about varicocele. They are the single most common cause of male infertility, responsible for a whopping 33% of cases. The good news? They're surgically correctable. We grade them using an ultrasound on a scale from 1 to 5, based on venous reflux and dilation. Grade 1 is basically just reflux in the inguinal region during a Valsalva maneuver, while Grade 5 is so severe you're seeing reflux even without a Valsalva. It's a progressive scale of venous incompetence that directly messes with testicular function. Let's shift to Section 3, Erectile Dysfunction Etiologies, looking beyond just the vascular side of things. Entering our second major clinical pillar, when a patient presents with ED, the list of potential suspects is incredibly diverse. It could be neurogenic, like from a spinal cord injury. It could be hormonal, drug-related, an anatomical issue like Peyronie's disease, or even psychogenic. However, our main focus for this explainer, and the primary reason we bring in advanced imaging, is to evaluate those vasculogenic causes. Specifically, we need to differentiate between arterial failures and venous failures. And this brilliantly illustrates right where all the action happens. Notice the two corpora cavernosa, enclosed really tightly within Bunck's fascia. Right smack in the center of those are the cavernosal arteries. Grasping this contained, highly pressurized vascular space is the absolute key to understanding both normal function and exactly what happens during vasculogenic failure. Which brings us to Section 4, the mechanics of an erection. Let's walk through the step-by-step process. To recognize the pathology, we first have to deeply understand the normal physiology. An erection is just a beautifully coordinated interaction. Step 1 is parasympathetic activation, which causes the smooth muscle of the cavernosal arteries and sinusoids to relax. Step 2, that relaxation drops resistance, leading to a massive increase of blood flow. Step 3, the sinusoids fill up and distend. And finally, Step 4, this distension physically compresses the emissary veins right against the tunica albuginea, dramatically decreasing the venous drainage to create rigidity. It's an amazing sequence.
Looking longitudinally, you can see the cavernosal arteries branching off the internal pudendal arteries, running right through that spongy tissue. When those sinusoids expand, the blood simply gets trapped. The deep dorsal vein and the cavernosal arteries interact in this really delicate balance of inflow and restricted outflow. If either the inflow is too weak or the outflow is too leaky, the entire system fails.
All right, Section 5, the Penile Doppler exam. This is our primary investigative tool.
So how do we actually test this system in real time? We use the Penile Doppler exam. It's an objective, dynamic test. We start off with a baseline spectral tracing in the flaccid state. But to actually test the hemodynamics, we have to artificially simulate an erection using an intracavernosal injection of a vasodilator, typically PGE1 or papaverine. After that injection, we carefully measure the spectral tracing at precise intervals of 5, 10, 15, and 20 minutes to watch how the hemodynamics evolve. Over those 20 minutes, we watch the patient progress through some very distinct spectral Doppler phases. In phase 0, the flaccid state, flow is monophasic with high resistance. Following the injection, phase 1 begins with filling, characterized by a really sharp increase in peak systolic velocity or PSV. In phase 2, tumescence, intracavernosal pressure rises, causing a decrease in end diastolic velocity or EDV. By phase 3, full erection, the pressure is so high we actually see diastolic flow reversal. Finally, in phase 4, true rigidity, diastolic flow is completely absent.
Notice how perfectly these waveforms map directly onto the physiology. Look at phase 2, tumescence. You can see that classic dicrotic notch appearing right as resistance increases. And look at phase 4. The ultimate goal, the holy grail of a competent vascular system in a rigid state, is completely absent diastolic flow. Blood rushes in during systole and it is locked tight during diastole. Absolutely zero leakage.
Finally, Section 6, diagnosing vascular dysfunction by actually reading the numbers.
This is where we look at the hard data to diagnose specific failures. Arterial insufficiency is evaluated by looking at peak systolic velocity, basically checking if enough blood is getting pumped in. Venous incompetence is evaluated via end diastolic velocity, checking if the trapdoors are actually closing properly. But listen, here is the golden rule for this entire workup. Venous competence can only be accurately assessed if arterial flow is proven normal first. Think about it. If you don't have enough pressure coming in, the veins won't compress anyway, leading straight to a false positive for a venous leak.
So the crucial point to remember is this threshold, 25. A peak systolic velocity of less than 25 centimeters per second indicates severe arterial insufficiency. Considering a normal PSV is well over 30, if the peak inflow is dragging under 25, the pump is definitely failing. The smooth muscle simply isn't getting enough blood supply to even initiate the process.
On the other hand, what if the arterial supply is great? Say the PSV is booming over 30, but the erection still fails. Then we look at the end diastolic velocity. A persistently high EDV, specifically greater than 5 centimeters per second at maximum tumescence, screams venous incompetence. The emissary veins are failing to compress. The blood is just draining away way too quickly. It's literally like trying to fill a bathtub with a massive leak right in the drain.
Now, while diagnosing this is super satisfying, we absolutely must be prepared for procedural complications. Because we artificially induce this state with medication, what happens if the erection simply won't subside? This is what we call low-flow priapism. If an erection lasts over 4 hours, it becomes a medical emergency requiring active management. Our detective work pauses right there, and we intervene, typically by administering an intracavernosal injection of an alpha agonist like phenylephrine to force venous drainage and resolve the erection.
Which brings us to our closing thought for this explainer. The main role of Doppler imaging is to differentiate between vascular and non-vascular causes. By understanding exactly when to order an ultrasound versus a truss, and by fluently reading the exact PSV and EDV hemodynamics, we totally remove the guesswork for male reproductive health. So what does this all mean for you? How will mastering these precise step-by-step diagnostic pathways transform your confidence the very next time you walk into the clinic tomorrow? Keep that in mind and keep investigating.